welcome to today's PharmaSimple clinical question time case study. Today we're going to be discussing another cardiovascular based case study, this time revolving around atrial fibrillation, also known as AF. So let's crack on with it. A regular patient of yours, 75-year-old Mrs. AF, tells you she's been getting these dull headaches after starting her AF medication a few weeks ago. Mrs. AF goes on to inform you she's also been getting quite a bit of constipation as well, which she thinks may be from stress since it began round about the same time as when the headache started. Mrs. AF says even her sister's famous prune juice hasn't helped increase her bowel movement. She hands you the following prescription, informing you she went to see the GP to repeat her prescription and give her something for her problems. Identify the 2 drug therapy problems present. Now, atrial fibrillation, or AF, is a type of irregular heartbeat that we synonymously conform as an arrhythmia. Now, it normally happens in patients with a fast heartbeat, although it can be asymptomatic in many patients. Now, electrical activity is what regulates a patient's heartbeat and tells the heart when to beat. That electrical activity is determined by electrical activities sent down sequentially through 3 nodes in the heart. So that's the SAN, also known as the sinoatrial node, the AVN, atrioventricular node, and Purkinje fibers, which are then sent through down the bundle of His. Now, most arrhythmias are caused by the formation of what we call reentry circuits, and this disrupts electrical conduction in the heart, and it most commonly occurs in the atria. So it just the electrical activity sort of goes in a circle before going back down, and so the heart can, contract irregularly. Now, because the most common one that occurs in the atria, that's why it's known as atrial fibrillation, because it occurs in the atria. Now, the name fibrillation comes from looking at the electrocardiogram, the ECG, and noting a fibrillating baseline, amongst other characteristics. Now, if you want the full deep pathophysiology of arrhythmias, reentry circuits, and CABANS, watch my earlier animated case study video, which is actually linked in this video and in the video description below. Now, this disruption in rhythm, as I said earlier, may cause the heart to contract irregularly. In essence, it actually fails to contract adequately, such as in the atria. Now, this can cause stagnant blood pooling to such an extent in the heart chambers that if it gets big enough, it can cause a clot to form. Now, this clot has the ability to pump out most commonly in the brain, and what happens is, if it lodges in the cerebral arteries, this can starve the brain of oxygen, resulting in a stroke, specifically an ischemic stroke. Now, about 85% of strokes are ischemic in nature, i.e. caused by starvation of oxygen, with the other 15% caused by bleeding in the brain or hemorrhagic stroke. Now, often a rate control strategy is implemented where a reduction in heart rate can affect the electroactivity to the extent that it actually breaks these reentry circuits. So this gets the patient's heartbeat back into sinus rhythm, preventing these clots from forming. Now, first line drugs to help with this rate control strategy are beta blockers or rate limiting calcium channel blockers. And rate limiting calcium channel blockers are calcium channel blockers that actually act preferentially on the heart. Now, taking this back to Mrs. AF, we can see that she's been given a potent rate limiting calcium channel blocker, verapamil. So that's one thing that we can tick off. Now, patients usually have their stroke risk assessed using a clinical aid known as CABANS. Now, CABANS uses a points-based system with different points awarded depending on the risk factor present, and it's actually an acronym for these different risk factors. So if we break it up, so C stands for congestive heart failure. That actually gives a 1 point. H is for hypertension. That gives 1 point. A is for age. That's more than or equal to 75 years. That gives 2 points, because the older the patient is, especially over that elderly bridge of 75, the more risk they are at getting an arrhythmia or irregular heartbeat. Diabetes mellitus counts for 1 point. Now, a previous stroke or TIA obviously will conform to 2 points. Vascular disease is obviously going to conform to 1 point. Now, age 65 to 74 years conform to 1 point. And sex of the patient, if it's female, conform to 1 point. Now, say a patient, this is an important note, say they only are female, they don't have any other risk factors, then you wouldn't count that as a risk factor. That can only be added on if there's another risk factor present in, say, a female patient. It can't just be used alone. Now, if we, once this is calculated and all the points are added together, you infer using a class table. So it's normally split into 2 points, 1 point, and 0 points. Now, 2 points is classed as high risk of stroke. These patients, it's strongly recommended that they put on an anticoagulant. Patients that have 1 point, they're at a moderate risk of a stroke. And so you usually recommend an anticoagulant or an antiplatelet. And 0 points is low risk, and that's often no treatment or an antiplatelet. Now, obviously, you have to take into account other factors, other comorbidities, other medication, and use your clinical judgment based on the patient. Now, if we apply this back to Mrs. AF, we can see she's 75 years old. So she automatically gets 2 points. So she's 75. That's 2 points. And we also know that she's female. So that's 1 point. So that means that her total points comes to 3 points. So we should put her in the strongly recommended anticoagulant, because she's obviously at a high risk of developing a clot. Now, if we take that back to the prescription, we can see she's been given an anticoagulant. She's actually been given a specific type of anticoagulant known as a XABAN. Now, these are actually classed as one of the newer or novel oral anticoagulants, a NOAC. Now, these are being more and more prescribed instead of the more conventional anticoagulant that you've probably heard of, warfarin, sometimes nicknamed rat poison. Now, the reason why NOACs are given more and more these days are because they have a reduced or equivocal bleeding risk according to studies. They're cheaper long term, so the tablet itself isn't cheaper, but long term, you don't have to do any expensive INR monitoring, and there's way less interactions because it affects the isosomes to a lesser extent, so it has less interactions. So that's from the CP450 system. Now, Mrs. AF has actually started to complain of headaches since she started this rate-limiting calcium channel blocker. If we actually look back, that's one of the first things she complained of. Now, you actually need to think about, is this risk of bleeding that you can get with anticoagulants since they thin the blood? Although that in itself is actually a misnomer. XABANS actually work on the coagulation cascade in a specific way. So they're what we call factor 10A inhibitors. So where's factor 10A? So factor 10A is an activated version of factor 10, which is a specific vitamin K dependent clotting factor found in the liver. Now, if we zoom in, because we won't go over the whole coagulation cascade, we'll zoom in on a specific part that's relevant to this. So normally you have what's called prothrombin, and that's converted into thrombin. And thrombin actually catalyzes the conversion of fibrinogen to fibrin, which is a clot, a fully formed clot. Now, that prothrombin to thrombins catalyzed by factor 10A. So obviously you can see that XABANS actually inhibit that factor 10A. So the clot's not formed because you don't get any thrombin. Now, obviously, if there's too much inhibition, so you haven't got enough clotting occurring, that can lead to bleeding. And so if you look back at Mrs. AF, there's a rare risk of getting an intracranial hemorrhage, which is bleeding in the brain. Now, usually this headache is sudden and more severe, and usually there might be other symptoms that come along with it, like nausea, vomiting, and the onset's usually much quicker than these few weeks that she's been saying, so it's unlikely that Mrs. AF is actually suffering from this. Now, it's actually quite common to get headaches with Rivaroxaban, and it's not due to this intracranial hemorrhage. So it's not that well understood, but it's believed to be due to what we call arterial vasodilation. So systemic arterial vasodilation. So causing vasodilation of cerebral arteries, so those are arteries that lead into the brain, causes an increased flow into the brain, and that's thought to what causes these headaches that many patients get with Rivaroxaban. Now, you can further, question the patient on top of this, as well as checking, any associated symptoms like nausea, vomiting, the levels of consciousness. If there's anyone that, they're with, that'll be able to give an account. But based on what we've got, it's probably unlikely. Now, you can discuss this with the prescriber and the side effect if it persists, informing them the situation and maybe give an alternative anticoagulant or come to some sort of agreement. So with the first drug therapy problem identified, let's go on to the second one. Now, calcium channel blockers have the potential to cause constipation, with the most common being caused by verapamil. That's actually the most common calcium channel that causes constipation. Now, they do this by inhibiting colonic nerve activity, and that actually reduces peristalsis. So they inhibit colonic nerve activity. So the food's not propelled as quickly along the bowel. Now, it may be appropriate, to inform the clinician to try an alternative drug if the specialist thinks this is okay, and discuss with them. but we may need a more thorough background on the patient before this decision can be made, and it might need to be discussed. Now, say, I don't know, for some reason that verapamil is the only drug that can be given, and all we can do is give a laxative, a bulk forming laxative. This is actually the worst type of laxative that can be given in this situation. And if we look, Mrs. AF's actually been giving a bulk forming laxative, aspergillar husk. Now, you're probably thinking, okay, well, why is this? Now, bulk forming laxatives rely on their ability to bulk up fecal matter. So they use their high fiber content to bulk up the fecal matter, and this bulking action is used to help stimulate the colonic nerves and cause peristalsis. So they rely on their bulking up to, stimulate this nerve activity. Now, if you're inhibiting colonic nerve activity and you've got a laxative that relies on bulking up to stimulate this, what's going to happen? It's not going to go anywhere. It's just going to get bigger and bigger and bigger because the nerves are inhibited, and you can actually cause intestinal obstruction if it gets bad enough. So you're actually going to compound the problem by giving this laxative. Now, the most appropriate laxative would probably be one that stimulates colonic activity. So if you stimulate it, you're actually going to antagonize this effect, this constipation. And then obviously you're not going to get, this inhibition of colonic nerve activity. And so you will be able to increase peristalsis. Now, using what we know, that would mean a stimulant laxative, because this stimulates colonic nerve activity, would be the best type of laxative to give. And an example of this is Senna, and that will actually help, move the stool along. Now, you can also give an osmotic laxative. Say, for example, the patient says, oh, my stools are really hard, or they're like, little pellets. It might be a good idea to help draw water into the, stool and to help soften it. And that will help reduce the risk of tearing the anal lining by forcing these little pellets through, and reduce the risk of, say, hemorrhoids occurring. So, a lot of the time they may give both as well, depending. But obviously you'd have to use your judgment. Now, with the second drug therapy problem identified, obviously you discuss this with the patient and discuss this with the clinician, but this is just in case that happens. So we've identified this. Now let's move on to the second drug therapy, the patient query, sorry. So second part of the question, while sorting out Mrs. AF's drug therapy problems, she asks if it's okay to have St. John's wort with her medication, since she saw in an article it's meant to be good for relieving stress. She asks you for your recommendation. Now, St. John's wort's a herbal remedy often used to help lift mood. This means it can be used in many affective disorders, including depression, anxiety, and anxiety can actually be a symptom of depression. Now, St. John's wort is known to cause induction of many isosomes, which network to make up this CEP450 system found in the liver, also known as cytochrome P450. Now, the cytochrome P450 system metabolizes many of the drugs that we see taken by patients, and many drugs are metabolized by a specific isoenzyme called CYP3A4. Now, this includes verapamil. Verapamil is actually a substrate of CYP3A4, and overall, St. John's wort has many interactions because it actually inhibits this CYP3A4. Now, if verapamil is actually broken down by this, St. John's wort actually induces the CYP3A4 enzyme, so it induces. Sorry about that, guys. So, yeah, because it causes induction of the CYP450 and specifically CYP3A4, it actually causes increased protein synthesis. So that will help make more CYP3A4 isoenzymes. That means there's more that are getting to work, and that means you're going to get a decreased concentration of verapamil. Now, if there's less in the blood, it means it's less likely that the reentry circuits are going to be broken. So there's going to be an increased risk of a clot as a result. So the patient might be at more risk. Now, you have to be careful, and this is just a good general rule of thumb, but having a drug that, induces an isoenzyme, because this protein synthesis is such a slow process, it normally can take weeks for it to occur. So sometimes people may not take this interaction as precedent as, a drug that causes inhibition of CYP enzymes, but that's just something to hold in the back of your mind. Now, this should be relayed to Mrs. AF in layman's terms, and if she feels stressed out that, I'm really getting, anxious, I need something, then it's probably good to refer her back to her clinician, like her GP. Maybe signpost her some mental health charities that can help her with stress, as well as, group support therapies, which are quite good in the community, orienting towards issues that can help her. Now, that wraps up today's case study. Please don't forget to subscribe, like and share, and I hope you got some benefit out of it. Don't forget to hit the bell symbol to make sure you get notified of future videos.